I am going to talk about mood disorders today. I'm probably going to focus a bit more on unipolar depression, just because of what we've got time to cover in 30 minutes. But during the Q&A, very happy to go across the spectrum, excuse me, including bipolar disorder. And look, it's thanks for that kind introduction, by the way, Jim, and it's really nice to join everyone again. So what's, now if I can get my slides to move, life will be even better. Why is this an important topic? Well, I suspect in many ways the people I'm talking to don't need persuading, really, but I keep going back to this data from the Global Burden of Disease study. Some of you know this study done by the World Health Organization, or auspiced by them, which looks at the global cost of all health conditions. And in this particular measure, it's disability as measured by life years lost, where a person cannot be productive for a year because of illness. In this version produced a few years ago now, depression was estimated to become the second leading cause of disability by that measure across the globe. And in the most recently published version, which unfortunately I haven't got the updated slide with me, it's estimated to be the leading cause of health-related disability, which is quite an extraordinary thing. It's not a good thing. I think some people say, well, you know, then it'll get more attention. I hope so, but it also says, gee, we've got a lot of improving to do. Interestingly, in answer to the question, how come it's growing in importance, if you look back in the 1990 estimates, there were a number of infective diseases in the developing world that have generally come under somewhat better control. And you know, the sad news is you can overcome particularly some of those perinatal conditions, but you can get depressed. So we've really got a global problem. And the data says that it is indeed a global problem, with annual rates of depression in pretty much every country studied, ranging somewhere between 5 and 15%. There are a couple of outliers, but I suspect personally that's a bit like the error of measurement. You know how they keep saying that with the polls for the election at the minute? Oh, a 1% change is within the error of the survey. I think the global rate is around 5 to 10% per annum, and in every country studied, twice as common in women as men in adults. In adolescents and older people, it sort of evens out. And some really interesting theories about why that might be, but we are talking about a huge global disease, is the point. A couple of comments about diagnosis of depression, because this sometimes comes up before we burst into the treatment stuff. And I've drawn here in these slides from DSM, which some of you will know is the American Psychiatric Association's 5th edition of their textbook, to try and provide consistency in how doctors and others make the diagnosis of psychiatric disorder by outlining the symptoms. It divides things up into bipolar disorder and depressive disorders, the most common of which is major depressive disorder. They also acknowledge premenstrual dysphoric disorder, and we've got a question about that. They also acknowledge a substance abuse-induced mood disorder, or something due to a medical condition. One of the really interesting and unusual ones in there is disruptive mood dysregulation disorder. And you might reasonably think, what on earth is that? What a strange name. It's actually classified by some people as one of the bipolar disorders. Some of you will be aware about a decade ago, there was a growth in the rate of diagnosis of bipolar disorder in very young people under the age of 10, often called prepubertal bipolar disorder. Historically, we thought this is a very rare condition, and suddenly, particularly in the States, it was diagnosed quite frequently. And there was a bit of consternation because that, involves putting very young people on some pretty significant treatments. And, what's that about? There was an acknowledgement that perhaps some of these children do have mood dysregulation, but really it's not appropriate to be making a diagnosis of bipolar disorder. That's all I really want to say about that, but that's what that tag disruptive mood dysregulation disorder means. Now, the other thing that DSM-5 tries to do is acknowledge that not all depression is the same. Depression can be divided up according to severity. It can be divided up into age of onset or time of onset, like peripartum, around the birth of a child. It can be divided up according to how successfully it's been treated. Are you in full remission or partial? Probably most significantly of all, it can be divided up into whether it's a single episode or recurrent. And we'll talk a little bit more about that in a minute. And of course, it can then be divided up depending upon which symptoms this person has. So depression is not the same for every two people with it. That's partly reflecting they're different people. But it's also different in the kind of symptoms it can cause. So for one person, the prominent symptom is anxiety. They may have had an anxiety problem beforehand that's got a lot worse now, but it's the main symptom. For others, it's a melancholic picture where they feel particularly slowed up in their speeding and in the speed of their thought and their movement, and are really disabled by that. For some people, a small percentage, it can involve psychotic features that are related to the depression. Another group is so-called mixed depression, where they actually have some features of depression and some of mania at the same time, which is a little bit hard at first to wrap your head around until you see it. And then you go, right, okay. And obviously in that person, we're wondering, are they going to go on to have bipolar disorder? Now, sometimes you just hear depression referred to as a single entity. And the main point of this bit is to emphasize, no, it's a complicated, really broad set of conditions that fall under this heading. I talked a little bit about maybe the most important of those subdivisions is whether it's a recurrent depression or not. This is quite an old study now, and what it shows is that when you've had one episode of depression, and remember the lifetime rate is about 20%, your chance of having another episode in the next 5 years go up to 50%. And by the time you've had 3 episodes, your chance of having another episode in the next 5 years is over 90%. Now, treatment can change that. But what it shows is that depression rapidly can become a recurrent problem. And that's really what we want to prevent with, if you like, good early intervention. We know that that probably is the result of changes in your social situation, in your psychology, and in biology, that it becomes this progressive recurrent condition. Want to stop that. And our aim really must be to arrest the condition wherever we can. What we also know in this study, this is a survival study where it looks at how likely you are to relapse over time, depending upon how many episodes you have had, and whether they've got completely better. So if you look at the brown line at the top, they're people who got completely better from their episode and have had less than 3 episodes. So you'd expect them to do the best. And by 500 weeks, still about 40% of them haven't relapsed. It's a pretty fair effort to follow people up for 10 years. The other 3 lines are people who've either had 3 episodes or have got some residual symptoms. So they didn't really get fully better. By 6 years, almost all of them had relapsed. So this strongly supports our aim should be get treatment done properly so the person is in full remission wherever possible, and try to stop them having multiple episodes. I do want to point out, it's not that everyone relapses straight away, and it's not that this trajectory can't be changed, excuse me, with treatment. I want to make that very clear. I see a comment already from Alicia about the subtype of people with anxious distress, how challenging that can be to provide treatment for, and also indeed to suffer, more importantly, to suffer from. And I think that's very true. Profound anxiety, we know, can be one of the most disturbing symptoms of depression, and something we really need to be very active in dealing with. That's absolutely true. All right. So I've mentioned a little bit about these essential features of the different types of depression, and I won't dwell on them further. I did threaten to talk a little bit about guidelines today, and look, I won't go through them all in detail. This is the latest Australian New Zealand College of Psychiatrists guidelines for both bipolar and unipolar depression. There's some others available. This one was published in our local journal and is freely available on the College of Psychiatrists website, ranzcp.org. It's a pretty imaginative name, isn't it? Beyond Blue has guidelines about the treatments of depression. Therapeutic Guidelines is another group that produces Australian guidelines. So these are not the only ones, and I acknowledge, yes, there's a group of clever people and a couple of hangers-on involved in producing it like me. But I think they do provide quite a lot of information in addition to the direct recommendations about treatment. There are points in this that people debate strongly. I will acknowledge that, and that's as should be, because we don't know everything about the treatment of depression. What do these guidelines say? Fundamentally, they say in treating depression, our primary aim should be full functional recovery. So this is getting rid of all symptoms, and it's getting the person back to full function. And we'd all acknowledge that sounds like a desirable goal. Previous guidelines have tended to split depression up into mild, moderate, and severe, and said for severe depression, generally we would recommend biological therapies, medicines, and so on. In these guidelines, we said, well, look, that's true in some cases and some people's preference, of course. But actually, for the majority of people with depression in the community, psychological interventions will be useful. So psychotherapy should be offered to everyone. Proper lifestyle advice, diet, exercise, and so on, should be offered to everyone. We would then add medication as an option, sometimes right from the start, sometimes dependent on the response. Importantly, not waiting for too long, and that's a common problem in depression treatment, that we wait for too long with things that don't work. And then there are options at the end where things are not getting better. And sometimes guidelines and psychiatrists love talking about what they would choose as the third, fourth, fifth thing, but actually it's really important that we get the first few right and hopefully don't get to the third, fourth, fifth thing. That would be desirable, wouldn't it? One of the questions I get asked a lot is, so which antidepressant do you use first, Mal? And look, if I'm absolutely honest, I don't get to choose the first antidepressant that often. As a specialist, people have often tried things now, remembering that over 80% of the antidepressants in Australia are prescribed at the start by GPs. In the guidelines, we moved away from saying first line, second line, third line antidepressants, and we talked a little bit more about what are some of the first things you might choose. Now, This set might interest some of you who know a bit about the antidepressants. How did we choose this group of 7? We chose based largely on a network meta-analysis, a big study of all the trials of antidepressants we've got, done in 2018, published in The Lancet, led by Andreas Cipriani, that had 500 studies and over 100,000 patients in it. And it came up with these 7 antidepressants as having the best overall combinations of efficacy and tolerability. It doesn't say they're all the same. So amitriptyline, an old tricyclic antidepressant, is not as tolerable as the newer ones in that group and not as safe. So we wouldn't say use that first, but we would say it should be somewhere in your early choices as an option. Some of you might be surprised to see bupropion there, which isn't listed as an antidepressant in Australia. It is in New Zealand, where these guidelines also cover, and actually has international evidence that it can be a very useful agent for some people. So generally we're saying, you'd pick from these guys for your first few choices, unless there was a really good reason for this person not to. Really importantly, how long should I stay on an antidepressant before I decide this one isn't the one for me? This is a classic question. And it's a really important one, isn't it? Because waiting for weeks and weeks when you're not well is not good. We came to the conclusion, after a lot of debate about this, that actually a minimum of 3 weeks at a therapeutic dose should be done with each antidepressant. Generally, the evidence says that if nothing's happened by 2 weeks on a given dose of a given antidepressant, you can probably go ahead and increase it. Many of you have probably heard that idea of waiting 6 to 8 weeks, but generally that time frame is for a complete response. But you can see the beginning of a response earlier. And if there's not much happening, it's really time to move on, not linger around for too long. What we're looking for, again, and this graph demonstrates that, is the person who's got, ideally, a prompt, complete response. What about this group who take a little while to get going, but eventually get a full response? As I'm suggesting, we think that's a pretty small group. So on balance, if nothing's happened by around 2 to 3 weeks, cut your losses, increase the dose, or change. Really important. Just as important in the management of depression is identifying what led up to the episode, nothing surprising, and what are we going to do to prevent relapse? Now that, given what I've already said, that sounds dumb, right? Well, that should be incredibly obvious. Well, yes, but we don't always get round to it, do we? We feel a bit better and we want to forget about this bit, right? Or this is a bit hard to work out. I just want to get fixed. Do the work. We don't want this to become a recurrent illness. What about people who don't get better, which is often where someone like me comes in? We have a series of strategies we can look at here. Review the diagnosis. Get a second opinion. Is there some other problem I'm missing? Increase the dose of antidepressant. Add in something that can augment the antidepressant, or switch. But actually, probably the commonest reason that people don't get better with any treatment is they don't take it. So this was a study John Tiller and I did a number of years ago that looked about 100,000 Australians with fully subsidised antidepressant medication. On the vertical axis is what percent are still picking up their script. On the horizontal axis, it's how many months they've been on it. And you can see in the left-hand box there, after 3 months, 50% of people were still picking up a script only. Just because you're picking up a script, by the way, it doesn't guarantee you're taking it properly. Big problem. Is it better for psychotherapy? Well, the average number of times someone sees a psychologist under better access is 3. Now, sometimes that's because they don't have a major problem. That's possible. But probably it's because, similarly, a lot of people don't stick in therapy when they really should for treatment of the disorders like depression. Why might this gap happen? Mark Zimmerman a few years ago did a really interesting study asking doctors and patients, what's the most important thing in getting better? Doctors said, getting rid of the symptoms. Patients said, in order, number 1, I want to feel optimistic and self-confident again. Number 6 was I want to get rid of symptoms. So it's kind of like sometimes we're singing from a different hymn sheet. So I think the treatment's working on number 6, but you're saying, well, it's not done the top 3 for me, I'm going to chuck it. And because, look, I don't want to kind of offend you, I just won't get around to telling you I've done it. Happens all the time. So what do we do about that? Well, one of the first things we do is take into account what you want. This is a really interesting and simple study done a number of years ago that looked at giving people with mild to moderate depression psychotherapy or medication and said, over 16 weeks, what's the difference? Turned out for mild to moderate depression, they're about the same. But at the start of the study, you were asked, which would you prefer? You didn't get your choice. You got distributed evenly no matter what you said you'd prefer. But at the end of the study, they went back and said, okay, if you got your choice, did you do better than if you didn't? And the answer is yes. If you got your preference, whatever the preference was, you did better by 5 points on the Hamilton rating scale for depression, which is actually bigger than the difference between medication and placebo. So getting your choice matters. Maybe we should listen to choices a bit more. So this is good grounds for saying we should engage in treatment in a proper shared decision-making process. A good two-way exchange where we convey information, we deliberate on that information, and we come to a shared decision together. The evidence is if we do that, it's much more likely you're going to adhere to what we recommend. Surprise, surprise. Now, sometimes it's not a complex thing. It's, tell me a bit more about that. Oh, yeah, that makes sense. I'm happy to go with what you recommend. And sometimes it's, look, you can recommend what you like, but if it causes this problem, forget it. Well, I'm better off knowing that, aren't I? Because there's no treatment that works if you don't take it. Going back to not response, what other thoughts about that? This is often where we get into perhaps many of your questions about what do we do when things aren't getting better. We've got this term, treatment-resistant depression, where people have had 2 antidepressants at proper doses and they haven't worked. It's a bit of a problematic definition, isn't it really? Because given what I've already said, we should be including psychotherapy in that definition. And it doesn't really account for the fact that there might be biopsychosocial factors like a really difficult job, or you're dealing with cancer, or whatever, that are complicating the treatment. And the term treatment-resistant depression, I don't think I've ever said to a patient you've got treatment-resistant depression, because that's a bit scary, right? That's not going to make you feel better. Particularly since at an individual level, maybe it's just because we didn't pick the right treatment for you the first time round, because we're not very good at picking that. What we do know is that once you meet this definition, the costs of your treatment go up significantly. Now, that doesn't worry you necessarily as an individual, although it might if you're footing the bill. What we also know is that sadly, if you develop treatment-resistant depression, your prognosis is worse for relapse and ultimately for life expectancy. And that's a scary topic to bring up, but it's important. With a lot of that change in life expectancy being not due to suicide, but due to poorer physical health. So earlier death due to the common causes of death like cancer, heart disease, metabolic disease that are not getting picked up and treated. That's something we should be able to do something about. So what we've said in the guidelines is that rather than focusing on treatment resistance, we need to focus on what do we need to do to get you better, and acknowledge the fact we're not good at predicting the best treatment for everyone first off. Discuss with you that it may take a few goes to get it right, and then off we go. Now, at this stage, we don't have many treatments that are specifically targeting treatment-resistant depression. Often options like ECT don't get used until someone meets this definition, unless things are very, very severe from the outset. Recently, we've seen the emergence of one treatment, and I'll just briefly comment on this before we do questions. Many of you will have read in the blogosphere all about ketamine and esketamine, and I'm just going to talk about it for a minute because everyone asked me about it. So going back quite a few years, there was studies with low-dose intravenous ketamine, a drug that is used as an anaesthetic. Often gets called a horse tranquilizer in the media. It's actually a human tranquilizer as well. And in low doses, it works on a transmitter in the brain called glutamate. And people trialled it in difficult to treat depression and had these fairly dramatic responses in a number of people. Where if you can see that top graph, some of the people who were getting ketamine were getting better within a few hours, which is quite extraordinary. None of our other treatments work like that at all. That wasn't everyone, I think is really important to stress. And it was an intravenous treatment, which is a bit complicated, right? What we found is if you only did it once, by the end of a week, most people weren't a lot better than they were originally. So that's a bit of a problem and would suggest probably you need it repeatedly. More recently, we've seen the development of esketamine. That's an intranasal version. Ketamine is a mixture of left-hand ketamine and right-hand ketamine isomer molecules. And esketamine, if you like, is the pure left-hand version. It's given intranasally, and there are now some large studies that say that may be a useful treatment in some people with treatment-resistant depression. And some of you may be aware that that's now started to become available in a limited fashion in Australia. We'll see what the Pharmaceutical Benefits Scheme decides about that in the near future, I think. But I think it's hopefully going to add another treatment. Won't be the answer for everyone, but another treatment to the range of things we've got available. I just want to skip to one last thing to comment on before questions. I'm assuming most of you online are Victorians, and you don't have to all be in a Zoom meeting, of course. And you'll be aware that there's been a Mental Health Royal Commission in Victoria. And of course, the Commission looked at many things. I gave evidence to the Commission before it tabled its final report, and some of it they liked, some of it they didn't. You can see this is a photo of me being removed at the end of the Commission. That's not true, by the way, but just in case anyone's confused, that is, of course, Julian Assange in a very undignified way being removed from the Ecuadorian embassy. It was a kind of bizarre scene, wasn't it? But what I said to the Royal Commission is one of the issues we have with severe mood disorders is that it's not easy for people to access treatment. With this challenge of there's a private sector that does a lot of that work, but there are barriers to access to that, money being one of them for some people. And the public system has been very preoccupied in Victoria with predominantly other problems like schizophrenia that deserve treatment. I don't want to minimise that in any way. The Royal Commission, I think to their credit, listened to a lot of submissions, and I think personally did a pretty good job. And they've come out with some recommendations about broadening the scope of treatment available in public mental health. And I'm hopeful that that means in the future we're going to see better access for people with mood disorders. Primary care will still have a very big role, and private too. But the more access, the better is something I feel very strongly.